The esophagus is there to transmit food from the mouth to the stomach. It has peristaltic contractions to help along the way. So disorders of the esophagus, not surprisingly, will present with dysphagia. I want to start off with an approach to dysphagia in general, and then go through each of the individual diseases one at a time. Let's start off with that approach to dysphagia. When you hear dysphagia, trouble swallowing, I want you to start thinking of two separate categories. That is going to be motility. And motility essentially means functional. The muscle actually contracting along the way. And the other is mechanical. This is an obstruction that's growing into the lumen. Because those obstructions have to grow, in general, they are progressive. That is, small caliber foods pass without problems, but bigger ones get stuck. Mechanical or obstructive dysphagia is going to be progressive. First from foods, then to liquids. Whereas motility, because it's a problem of the function of the esophagus, is not progressive and is dysphagia to foods and liquids at the same time. When we start working out both motility and mechanical issues of the esophagus, you realize that there's going to be a lot of overlap in the diagnostic workup. The first test for both is always going to be a barium swallow. And you should memorize what these look like, because that may be all that you are given, and you have to make the diagnosis based on the barium. The best test is going to be endoscopy with biopsy for both cases. And because motility is about problems with peristalsis, you can use a manometry in the case of motility, but you don't do that in the instance of mechanical. And then to treat these disorders, of course, you're going to treat the underlying disease. So let's go through the motility disorders first, and then we'll move into the mechanical. The first and the highest yield is achalasia and pseudoachalasia. The pathology of achalasia is the absent myenteric plexus. This is the absence of the inhibitory neurons so that the lower esophageal sphincter cannot relax. So it's always tight. And as a person swallows, a bolus of food gets stuck at that junction, so they'll complain of a knot or a ball of food stuck at the GE junction. That is mid-sternum. As we talked about, for a motility disorder, we're going to do barium manometry and endoscopy. Begins with the barium, then you get manometry, then do the EGD, and the best test is EGD with biopsy. Let's look at what these might look like. So the stomach here, down near the GE junction, is going to be normal. There's going to be a contracted lower esophageal sphincter so that any food that comes in will end up dilating the esophagus. This process, so-called the bird's beak, is pathognomonic for achalasia. Manometry will show that even without swallowing, the rest of the esophagus has no contraction. But the lower esophageal sphincter, abnormal tone that does not relax. You do the endoscopy with biopsy to make sure that you have the diagnosis of the absent myenteric plexus. But you really do it to rule out cancer. Anytime you have a luminal obstruction or achalasia, it must be biopsied because that might be cancer. Even if you have it clearly diagnosed by the bird's beak and manometry, you do the biopsy to rule out cancer because that cancer presenting as achalasia is pseudoachalasia. But if the diagnosis truly is achalasia, there's a couple of options you've got. botulinum toxin, esophageal dilation, and myotomy. Each of them has a role. Botulinum toxin doesn't last very long and should only be done in the cases where the patient is a really terrible surgical candidate. Otherwise, don't do it. It recurs too soon. Dilation carries a huge esophageal perforation risk, and you'd have to do it again and again. Don't do dilation. The answer you want to pick is myotomy. As we'll learn in the GERD lecture, if you take away too much of the muscle, you'll have a big open LES and you'll result with really bad GERD. Just as when you treat GERD with a Nissen, you can create an achalasia. So achalasia, biopsy to rule out cancer, don't do botulinum or dilation, do myotomy after confirming the diagnosis with manometry and EGD. The disease that is the exact opposite of achalasia is scleroderma. And scleroderma is a collagen deposition disease. Such that collagen replaces the smooth muscle of the lower esophageal sphincter. So the lower esophageal sphincter is no longer muscular and cannot contract. The patient is going to present with the symptoms of scleroderma or systemic sclerosis. Calcinosis, Raynaud's, esophageal dysmotility, that's what we're talking about here, sclerodactyly and telangiectasias, or pulmonary kidney heart involvement. Both of these disorders can present with this sort of esophageal dysmotility. The patient is going to present with relentless GERD because there is no lower esophageal sphincter. Acid is just allowed to come back up and erode the esophagus. The diagnosis, as we know, is made first with barium, then with manometry, and with endoscopy, with biopsy. In this case, the lower esophageal sphincter is wide open, and on manometry, even with the swallow, there is no contraction of the LES. So even before, after, during, this is just wide open and acid is allowed to come back up and burn the esophagus. Unfortunately, there's no treatment for scleroderma, so all we can do is treat the symptoms. You do that by using a PPI. And as we'll learn in the rheumatology sections, you should link up each diagnosis with serology. The CREST syndrome is usually associated with an anti-centromere, and systemic sclerosis is anti-SCL70 or anti-topoisomerase. The last of the motility disorders is going to be diffuse esophageal spasm. In this case, you've got random contractions of the esophagus. Nothing to do with the LES, as these other two diseases do, but the contraction of the esophagus occurs without swallowing. The patient's going to present with an MI. It's going to be a retrosternal chest pain, crushing in nature, better with nitrates and calcium channel blockers. The nitrates work to relax smooth muscle. This pain is caused by the muscle contracting really hard. So it looks like an MI. And to diagnose diffuse esophageal spasm, especially on the first time of their presentation, you have to rule out ACS, troponins, EKGs, and even a stress test if they got risk factors. But once you know it's not a myocardial infarction, that is, someone's been ruled out already, and they constantly recur with these symptoms, then it's time to make the diagnosis of diffuse esophageal spasm. And you do that with barium, manometry, and endoscopy with biopsy. Since there's these random contractions that you can't control or know about, you get what's called a corkscrew esophagus. If you hear the word corkscrew esophagus, or you see an esophagus like that's beads on a string, you've got the diagnosis. Manometry is going to show during an episode contraction at the areas that are contracted, and in between it's going to be the normal flat no contraction. This happens randomly in different places. The biopsy is not necessary in diffuse esophageal spasm, but you could still get it to make sure it's not something else. If you didn't have a clear answer on manometry or with the barium, you could do that. To treat, since this isn't a life-threatening illness, you simply use the things that make it better. You treat it symptomatically. You put them on calcium channel blockers, and then you use nitrates as needed. Okay, so this was the motility portion. We're going to move on to the mechanical portion next. In a discussion of the mechanical disorders, we're going to focus on the barium swallow and the EGD with biopsy. No manometry is needed. And remember, mechanical obstructions are going to present with progressive dysphagia. Food, then liquids. Let's start off with a Schatzki's ring. A Schatzki's ring is a ring at the GE junction. This is what it looks like. You have a normal esophagus with the stomach. But down towards the bottom you have this ring, which creates a narrowed lumen. But it's set up such that only large caliber foods will get stuck, and the patient will present with steakhouse dysphagia. This is how this works. The person goes through life normally cutting up their food without any issue. They masticate well and keep it small food boluses. They have no problem. Then they go to the steakhouse where they cut off a really big piece of meat. Don't chew it all that well and the food gets stuck. It's weird, but then they go through a long period of time and it doesn't happen again. So a person who has a poorly masticated large bolus of fluid infrequently is said to have steakhouse dysphagia, and that should tip you off to the Schatzki's ring. If you do the barium, you're going to see that at that point the lumen is narrowed, because up here barium fills the esophagus without problem, and as it gets to the ring it narrows. So you'll see the narrowed lumen. As we'll learn, a narrowed lumen is worrisome for cancer. So the EGD with biopsy shows that it's benign, it shows you the ring, and to treat it during the endoscopy, you lyse that ring and open things up. Very similar to the Schatzki's ring, there are going to be esophageal webs. But where they really come into play is in the Plummer-Vinson syndrome. You can have esophageal webs, and that's annoying because they get in the way of food getting down. But where it really matters is Plummer-Vinson. And Plummer-Vinson is going to be a woman with dysphagia, iron deficiency anemia, webs, and eventually esophageal cancer. The dysphagia comes from the webs, the iron deficiency comes from the webs, and it happens to be in women that this disease occurs. What it looks like are these webs in the esophagus that get in the way of food, and they can transform into cancer. The diagnosis is made with barium swallow, and you'll see the webs. You do not need to do an EGD with biopsy, not to diagnose esophageal webs. Instead, what you're going to do is give them iron to make up for their iron deficiency anemia, and then do EGD with biopsy. This is not a diagnostic step, this is a screening tool to make sure they don't develop esophageal cancer. Unless they actually develop cancer, you should not do esophagectomy. If you think about it, you might say, well, I know they're going to develop esophageal cancer, so why don't I just take the esophagus out and no big deal? It doesn't work. Breaking up the webs doesn't work. they still have risk of cancer, so they have to get screening UGDs. So the UGD is done to screen, and do not do esophagectomy, but do treat esophageal cancer when it eventually comes. Another one you're going to see primarily in surgery, not so much on GI, is the Zenker's diverticulum. And this is a board favorite because it's so easy to write the vignette about it. That's the diverticulum, the outpouching in the stomach. And in here is a little stick figure man. He's a stick figure man because he is undigested. This is the patient who's going to have undigested food stuck in his Zenker's diverticulum. You can imagine that undigested food in the back of your throat doesn't smell very good, so you're going to get halitosis. This generally is going to be an older man on the test, but age is definitely a risk factor. And the thing that's going to seal the diagnosis is regurgitation of undigested food. This is also someone who coughs and gags on initiation of swallow. But don't use that because that could be a stroke. It's the regurgitation of undigested food and halitosis that seals the diagnosis. The diagnosis is first made with barium, and the barium will fill the diverticulum, then EGD with biopsy, and you surgically repair. The last two we're going to talk about are going to be very similar to one another, and I want you to make sure that you understand the good comparison. We're talking about dysphagia in a patient, and we're talking about mechanical obstruction. We're talking the difference between stricture and cancer. The pathology of stricture is GERD. Stricture is considered grade 4 esophagitis as a product of GERD. Cancer is caused by GERD. That is, adenocarcinoma is caused by long-standing GERD in the bottom third of the esophagus. Strictures occur from GERD in the bottom third of the esophagus. That makes sense. The acid is coming up from the stomach, so all the damage is going to be done to the distal esophagus. I want you to keep in the back of your mind, another type of cancer, squamous cell, is caused by smoking and alcohol, and that is going to be in the upper third of the esophagus. So you're going to watch for these patients. Patient who has long-standing GERD develops progressive dysphagia and has weight loss. He has weight loss because he can't get the food down and then learns not to. In cancer, the person has long-standing GERD, develops dysphagia, and because the cancer is eating away and stealing all the nutrients, also weight loss. So you can't tell the difference between really bad GERD and the development of adenocarcinoma. Generally, what will happen in the case of cancer is you'll have transformation to a Barrett's esophagus, so their GERD symptoms will go away, but that's not reliable. The whole point of this discussion is to show you that you can't use the pathology or the symptomatology to differentiate the two. Instead, you have to use the diagnostic tests. Look for barium, and you're going to see a symmetric or circumferential loss of the lumen for stricture, and in cancer, you'll see an asymmetric. Let's see what that looks like. So this is the esophagus, and this represents the lumen. As a stricture develops, it narrows the lumen. Very much like a ring. And so when you do a barium, you're going to see the stricture site. Whereas if you have a cancer, you're going to have this fungating mass that comes off from one side. So it won't be clean. And it will be asymmetric. The diagnosis is definitively made with EGD with biopsy, where the structure shows no cancer, and EGD and biopsy of cancer shows you the cancer. And you must do the barium first to know where the cancer is. You don't want to just put a scope into a cancer, especially if it's squamous cell, top third. So you do the barium swallow to make sure you know where the cancer is, so that when you go in and biopsy it, you can. To treat a stricture, high-dose PPI, because it's caused by GERD, and dilation to open up the esophagus. Whereas cancer is going to be treated with chemo, radiation, and surgery, depending on the stage. So this back half, we talked about the mechanical obstructions. Progressive dysphagia. Soshatsky's ring is the thing that's always there, but they don't really notice, and you can just lyse it with an EGD. Plummer-Vinson syndrome, women with Webb's, iron deficiency anemia who develop esophageal cancer, screen them, no prophylactic esophagectomy. Zenker's, old guy with halitosis, regurgitation of undigested food, barium and EGD, and then be able to compare stricture, grade 4 GERD, with adenocarcinoma, sequela of GERD. And the difference being the barium swallow showing symmetric luminal obstruction for the stricture, whereas cancer has asymmetric, and everything is diagnosed definitively based on endoscopy and biopsy. That's disorders of the esophagus.